Welcome to Can I Butt In, the Bowel Research UK podcast, where we welcome bowel cancer and bowel disease patients, researchers, healthcare professionals and carers to butt in and share their experiences. We're picking a topic every episode and getting to the bottom of it. I'm your host, Sam Alexandra Rose. I'm the Patient and Public Involvement Manager at Bowel Research UK, and as a patient myself, I'm excited to bring more patient and researcher voices into the spotlight. Hi everybody, today we're talking about fit tests, an easy and convenient bowel screening method, potentially, but much more difficult for those who are visually impaired. I'm joined by Eamonn Dunne from Thomas Pocklington Trust, which is a charity that supports blind and partially sighted people. Hi Eamonn, welcome to the podcast.
Hi Sam, thanks for inviting me.
Thanks for coming. So do you want to start by just sort of introducing yourself and telling us a little bit about your role at Thomas Pocklington Trust?
Yeah, sure. My name's Eamonn Dunne, and I work for the charity Thomas Pocklington Trust, and I have done for the last 6 years now, so I'm quite a veteran really for our organisation. So as Sam says, we work to support in very many different ways blind and partially sighted people. And my specific role in it as partnerships and projects development manager is to look at health equity. So it's really good to be here today to talk to you about the fit test and bowel research, because this is one area that we've identified where there is a health inequity, and that's around the home fit testing kit. Do you want me to give a bit more detail about that, Sam?
Yeah, so should we start by explaining to people what a fit test is? So it stands for Faecal Immunochemical Test, which is quite hard to say.
I've got that written down in front of me, thank you.
I've got it written down too. So this looks for blood in the poo, doesn't it? That right. People might not be able to see with the human eye.
That's right. And as part of the government's health screening programme and ill health prevention strategy, the fit tests are sent to people who are registered with a GP. It used to be when they reach the age of 60, but they're gradually getting to grips with doing it from people from the age of 50. So you might not get one straight away when you're 50, you might be 54, but they're trying to kind of get, obviously with the capacity, to get down to the age of everyone who reaches 50 will get this test. They'll get a letter first to introduce the fact that this test kit is coming out, just to prepare people for it and why they're doing it. There are various campaigns through different NHS organisations, and perhaps your local GP will have some posters on the wall about it, or you might find out through other family members or whatever that this is a thing. And you'll get the letter, then you'll get about a week later, you'll get the test kit in a nice discreet envelope. And it's not the most pleasant thing to have to do, but the importance of doing it cannot be overstated, because picking up anything in terms of cancer early as possible is key to better outcomes. So I would, encourage everybody to respond to this as quickly as you can, really, because you only get follow-up letters anyway, so you might as well do it sooner than later. So the kit itself is basically gathering a sample of your poo, which is not pleasant and easy to do, but if you can forget the difficulties with it and the pleasantness for a while, think about the benefits of doing it. It's not that hard to do. And we're very lucky in this country that our health service is free at the point of delivery, so there's no charge for it. There's even a free post little cardboard envelope to send it back in. So what you will do, you will take a sample of your poo, which can be done in different ways. You can, without going into too much detail now, you can collect it in the toilet on tissue paper, and you take I've got one in front of me actually, but so I can actually do the actions. So you take a sample of your poo, a small sample on a stick, which effectively goes then into like a test tube type affair, but it's kind of flat, oval looking thing, which clicks closed and then gets sent back. And it's as simple as that. You just write your name on the sticker on it and send it back in the prepaid envelope. Job done. And then within a week or so, you'll get a letter back telling you either you're clear, there's no problems to worry about, or if there's any follow-up needed, that will be arranged as well. So it's very quick and efficient. And I've done this myself. Yes, I'm over 50. And so I can testify to how easy it is. That's relying on the fact that I am not visually impaired. Were I visually impaired or had dexterity issues, it would not be as easy as that, because you need to be able to see to do this test. If you've got low vision, there's probably ways around it using the current kit. But because of the effectively could be described as a health inequity for visually impaired people, based on a lot of discussions with people with lived experience, that the rate of return of the kits amongst blind and partially sighted people, we think, and again, we've not done any detailed research on response rates because the data is not really available currently, but we think the rate of return from blind and partially sighted people for the FIT test is relatively low. So, that means that you're more likely than if you're visually impaired, if that's the case, to go on and develop symptoms, which we obviously don't want people to do. And again, the problem with symptoms is you might not be able to spot the blood in your stool. So it's really important to do the screening when you get the opportunity. So because of that, we have worked with our partners in RNIB, the Royal National Institute for the Blind, who many listeners will know of already, and the NHS, to work on something called Fit Aid. And this is a kit that is very similar to the existing FIT kit, but it comes with a few modifications that allow people with reduced vision and or dexterity problems to carry out the test more easily. And I have a prototype in front of me, so although you can't see it, I can describe it in detail. It's different from the current kit in that it has a flat tray where you can easily click on the stick into the test tube. So it's more easy to kind of to do it cleanly without messing it up. It also comes with what's called a QR code, which provides a link to a website or video and audio content as well. So the idea is, even if you can't see, you can get verbal instructions on how to carry out the test and return it. And we think, we're just about to actually, Sam, to start testing, which I can talk about in a minute if you like.
Well, that all sounds really positive, and yeah, it's such an important issue to tackle, because you really don't want people to be at a disadvantage because they can't see that they have these bowel cancer symptoms. And you would have thought that actually a FIT test would be quite beneficial for people who are blind or are partially sighted, because of course they can't see if there is like blood that is visible to other people. If you're partially sighted, you can't see it anyway. So in theory, a FIT test should help with that, but it's no good at all if it's not useful for people who are blind.
That's right. And this is why we need to test it, because we've got the people involved on the team that are looking at it. Some of them are visually impaired, some are completely blind. So it's very important that we have lived experience informing this process. And also there are people with dexterity issues. So we've got to the point where we're ready to test it in the real world. And over the next few months, working with NHS local hubs across the country, people are being identified, and it's targeted then, but it sounds a bit sinister, doesn't it? People will be identified who are also at the age of ready for screening, but also are registered with a visual impairment. So they will be contacted and asked if they want to participate in this trial. And then they will get the Fit Aid kit with the adaptations. And then we'll test it in a live situation, really. We'll see how people find it, and we'll get some really good feedback. So if we then need to change the kit at all, or provide some differences in the communication strategy behind it, or figure out something else, because people will have ideas, people with lived experience of sight loss come up with some brilliant ideas for fixing things, because they're living their daily lives like that. So, they're very inventive. So once that trial has been carried out and we've got the feedback from it, that the plan then is to make sure that when someone reaches the age that they're ready for a screening kit to be sent to them, their local GP will automatically, because the system will work this way, will be triggered to the fact that they have a visual impairment, and it will be sent the alternative kit instead. So that means that the overall mission with this is to get the numbers of response rates from the asymptomatic and the symptomatic return of the kits, because it'll be easier for people to do, and we'll create more awareness around it. Because what my fear is that people get the letter, which there's been problems with NHS systems coordinating with each other. So the other things that we're working on, which I'll talk about a little bit later on, is around the accessible information standards. What that means is that people with communication needs other than the standard, 14 font size letter that most people get, will have their information on the NHS computers. And everywhere you go through the NHS or social care, that information will be picked up and your communications will be sent in the format that you have chosen. That's not there at the moment. So, when the letter goes out initially telling people about the FIT test, it doesn't pick up that knowledge. So everyone gets the same bog standard letter. But so that's something we need to fix as well, because there's no good getting a letter if you can't see, to tell you that if you want another format, please ask for it, because it's kind of a bit of a catch-22.
Yeah.
But that's what's happening quite a lot across other areas of health as well. But that's something that we're as a sector, we're looking at fixing as well.
I wonder if that's an issue with language as well. If somebody receives a letter in English and it says in English, if you need this letter in another language, it's probably not very useful.
No, it's not. And again, the communications across all different needs looking at, and the NHS have been, and they'll admit this themselves, they've been quite, they found it quite difficult to keep up with the need. Things like automatic Braille. So if I say I need my letter in Braille, for example, or I need my letter in Urdu, I need to get that letter before the appointment, not after it, because it takes extra days, because they've got to send out somewhere to get that printed. So we want either NHS organisation to have the capacity to produce those communication assets or whatever in the format people want, at the same time as the standard English size 14 font letter or whatever, and getting around some of the digital exclusion issues as well, not assuming everyone's got a smartphone, because they haven't. So again, it's making sure that people's needs are recorded. So there is a responsibility on the individual or patient to tell the NHS or their GP what their needs are. And again, that can be done when you go in for an appointment or to drop a prescription off or whatever. You can speak to the receptionist and update your needs. And I think GPs are going to get better at asking people for updated information. And the other problem that can often happen is staff that aren't particularly trained well on understanding the variety of different communication needs people have, whether it's people with a learning disability who need something in easy read, or it's Braille, or it's a different language altogether, and that people need their comms in. But as AI gets involved and starts to be able to make things like that easier, making sure that these things are checked first for making sure they're correct. But we should be able to do things more simultaneously than having to wait extra, because it isn't fair that someone has to wait a longer time to get a letter about an appointment, because there may be things they have to do in preparation for that, like fast or take blood pressure readings or whatever that is, that prep, because people are turning up to appointments having not done the preparation that the letter, which they didn't understand or couldn't read, told them to do. And so it becomes a do not attend event, as the NHS call it. So it's as if the person's just not bothered to turn up, which obviously isn't the case. And that currently is not monitored. So we want them to monitor those sorts of administrative misadventures a bit more carefully, so we can understand what the problem is.
So that's interesting about that, did not attend. Is that like a black mark against the person? Does that kind of count against them for future appointments or care? Or
well, I suppose technically it shouldn't, depending on how many times that happens. Different NHS bodies have different criteria, but what it makes it look like is if the NHS is all tickety-boo, it's the patient's fault, which masks the real problem. So, I mean, I know the government, we're talking about introducing charges for do not attend at GPs if people do it 3 times and they get charged. That's not currently in, as far as I know, but obviously there are human rights issues and things like that to consider with that. But there is an incentive for people to attend their appointments, because there's a perception, and you speak to people and they think, oh, I haven't turned up for an appointment, they won't give me another one. But not only that does that create that impression, but it also creates a delay in whatever the treatment is, and that delay could actually lead to kind of different health outcomes, worse health outcomes, because particularly with eye health, which I'm involved in, some conditions, if not treated early, can be irreversible or not treated at all. So we stress the urgency of getting things looked at quickly, and if the system is not helping with that, then that's something that we can fix.
Yeah. And again, just so important to carry out these fit tests and to follow up with any symptoms. And I imagine it's quite difficult as well, because somebody who's blind or partially sighted might have things that they ask people to help with, like a close relative or something, but doing a dipstick in your poo might not be something that people are comfortable asking for help with. And I guess that can be another barrier as well.
Yeah, absolutely. And people who live on their own as well haven't even got the potential for that. But I think again, it's just one of those taboo subjects. People are getting better at being able to talk and being embarrassed, which is, having talked about this quite a lot, it seems silly now, but there are still people who feel, that there's a bit of a taboo, especially maybe people who are not used to sharing things like that. People who it feels undignified, but I mean, really it shouldn't, because it's just another, it's just like snot or something like that, really. If you think of it like that, you wouldn't be worried about that. So that's what it is, So that taboo has been broken down. But I know that, when I got my fit test, I was like, oh God, I don't really want to do that. But then I thought about it and I thought, hang on, this is something that I'm being offered free that could save my life. So why wouldn't I? And then I thought about how difficult it is for those with limited dexterity and sight loss. I thought, shame on me for even thinking that this is difficult, because it's not for me. But it could seem impossible for someone who can't see. So anything we're doing around the fit aid test, anything we can do around, helping family members to talk about this with their parents or partner, because that conversation, it could be the hardest bit, is to actually, someone's like, I need help with this. Because, again, I've done it with my mother as well, actually. So I've talked from personal experience in terms of that side of things, the family member. And it's not pleasant, but I think it actually creates a bond in a way, because you're not comfortable, but if you get through that and it's a good outcome, it's like, you've done something we both didn't find very easy, but has actually led to a potentially health improvement.
Yeah, no, definitely. And you mentioned dexterity there as well. So the fit aid does that help people who have dexterity issues?
Yeah, I mean, dexterity issues come in all shapes and sizes. It could be, arthritis, or it could be just, an injury. Because, if you only got one hand, if your hand's damaged, or, there's all sorts of depletrins and all sorts of conditions that can lead to limited dexterity. But the fit aid does help, because it provides I wish I could show it to you on this podcast, but I'll describe it. So it's a rectangular piece of plastic with a sort of trough in the middle, which is just the right size for the test tubey bit that comes with it. So you can rest the test tube in the trough and click it closed. There's also a little stand to put it on as well, a bit like some of the stands you would have got with a COVID test, but it's built into the tray. And the tray has Braille instructions on it. Well, Braille instructions to show you how to get the other instructions, because we couldn't fit full Braille instructions on it. But and it also has the QR code with a very big, large picture about how you click the thing. You must click the test tube closed. So I think once we've had the trial with people with lived experience, we'll have a lot better idea about how well it works in the field. But we think, to get to this point, we've done quite a lot of research and user testing from our, kind of pool of people within our kind of realm now. But I think the real test is when it goes out through the screening hubs across the country, and we get people to test it and get the variety of people with different eye conditions, different ages, different circumstances, to kind of give us their feedback on it, really.
What feedback has there been so far? What have people been saying?
I think generally speaking, there's a kind of an impact from just discussing it, really, because I think, again, if you discuss this with people, and you then start to talk about the importance of it, and I think that's half a battle sometimes. It's like, once you get that out in the open and you go through the sort of stages of it, people are more willing to do it anyway. And if you provide them with a way that is easier than the standard kit, there's generally been good feedback from people. We did a feedback from people in Northumberland recently. Well, we didn't do it. Our local sight loss charity called Vision Northumberland did it. And there were some really good ideas on things like, for people who can see but have dexterity issues, to change the colour of the actual stick itself. So showing that where you need to get the poo up to this line, so a more contrasting colour. So that could be, that was just one idea that someone with lived experience came out with. It was actually quite a good idea. So the response has been quite good, but I think to get a true response, or a more effective response, we need several hundred people to test it across the country in different circumstances, so we can kind of look at the results we get from that, and just make sure that this is as good as it can be. Really, is there any other improvements we can make to the kit itself, or how it is communicated to patients? This is going to happen, and just making sure that we pick up any of their adjustment needs. The added value of this as well, it gives people a chance to give information on other needs they might have that they haven't already done, because it'll raise their awareness of the importance of making the NHS fully aware of every need that they have. because you can't blame the NHS for not responding to people's needs if they don't know about those needs. So it only picks up things at the moment that are currently logged on their system, but there are things which don't fall under a NHS code or have happened since you've last updated your requirements that have changed for you. Your sight might have deteriorated, your mobility might have deteriorated, so you might not be able to get out to appointments as easily. So the NHS needs to know these things. So I would always advise people, any opportunity that I have, to make sure your healthcare providers, or be it GPs or hospital, if you're currently under a hospital treatment plan, then just tell the reception person or the administrator that you discuss with, make sure they know about all your adjustment needs. And that's mental, physical, everything that would make your experience of healthcare more pleasant or less unpleasant.
Yeah, that's really good advice. So outside of the FIT test then, is there any other aspect of bowel screening or that the general kind of bowel health pathway? Are there any other issues that are difficult for people who are blind or partially sighted? I'm thinking about like maybe procedures like colonoscopies and things, or sort of general hospital stays and that sort of stuff. What other issues are there?
I think the main issues are, again, going back to the accessibility information standards, which is the NHS's own standard to communicate with people in the way that they have specified. Getting that right is like a foundation, and that will then help everything that flows from that. So in order to get people, they need to get to the hospital because oftentimes hospitals change their layout. So someone might be used, if the visual impairments, get used to a route. Once they've learned a route, provided it doesn't change, there's no obstacles in the way, they can independently, quite easily follow that route and get to where they need to go. The problem is when that route changes or something changes, maybe the clinic that they attend, or if they're going to a particular place within the hospital, it's important to know that before you arrive. So either that could be through audio recordings to describe people roughly where their clinic is in relation to the hospital entrance. There are all sorts of gizmos and apps now you can get that can help you get to where you need to be if you're tech savvy and you have a smartphone. So there are route finders and that kind of thing. Google Maps actually is quite good at getting you to the building, but once you're in the building, the internal mapping's not that good yet. And so even if you have got a smartphone, you might not be able to get to your clinic. So having trained staff at the forefront of the hospital, administrators, porters, anybody who's likely to, even cleaners actually, because they come into contact with people quite a lot, and to get to train those staff in how to interact with the visually impaired person, how to talk to someone, because that's, people feel a bit awkward when they don't know how to offer help. So there's basic things about using your voice, and don't use your gestures because people can't see necessarily. They might be able to see a bit, but don't assume they can. And trying to direct people with vocal instructions rather than visual ones. So, and the kind of general awareness about how to guide someone who's visually impaired, because oftentimes someone might need to go into the bowels of the hospital, as it were, to access the care they need. And even if you've got sight, it's really hard to find these places sometimes. It's go through car directs, down the green wing, 30 yards and then turn right, go up the stairs, that kind of thing. Yeah. So sometimes people, especially people who may have got frailty issues as well, maybe they're not steady on their feet, will need to be guided. So having someone in the hospital, front of house team who knows how to guide and is available when the person needs it, because the ward will be alerted to that because the patient's record has that on it, so they'll know there's a need there. Then that can be pre-planned, and so the person can get to where they need to be. Because the problem with especially with people who've got heart conditions and high blood pressure, trying to find your way around a hospital just increases your stress. So it doesn't help if you're there for your, for cardiovascular or whatever, to be more stressed if you've got visual impairment as well. And that's the principle that we try and adopt at Thomas Pocklington, is that people they have sight conditions, but they're also very much not just about their sight. They've got other health conditions and other aspirations and needs. So it's how do we help the people and the service providers, whether it's health, leisure, shopping, all of those, the places that people go where they want to be as independent as they can. We need to make sure that the staff and the layout of those places is appropriate as well. So there's not things in the way for people to trip on, like those awful yellow little triangle signs they put up when there was a wet floor kind of thing. I mean, I know why they do it, but because visually impaired people no end of problems, you know.
Yeah, I can imagine. I'm just thinking about the scooters that are all over the roads these days as well, or lying on pavements and things.
We've got a campaign for that one as well, if you want
Oh, do
our
you?
website. But yeah, to make streets accessible. Yeah, there is. I mean, there's an awful lot of things that people sometimes unwittingly put in the way of people, literally, that make it very hard for them to navigate around. You know, so we might do all the training, everything else, but if there's a scooter in the way and you trip over it and break your, bones or whatever, then that's not an outcome that we want. So we work with those providers, with our colleagues, to make the world a bit safer and more accessible, really. Yeah.
Excellent. Yeah, really important work. And just thinking about hospitals as well, thinking about like the hospital stay, I guess, is equally important for communicating with people. And I know when we talked last before recording, we were talking about somebody staying in hospital and they might hear somebody nearby but not be able to see them, and they might think, oh, is that a doctor? Have they come to tell me something? Have they come to do something to me? And if maybe it's just the cleaner or something, but you don't know, and then that's just must be massively increased anxiety because you can't tell what's happening.
It certainly does, and it can result in a poorer health outcome, because it could be as sort of simple as not being able to read the menu for the lunch, and maybe if they've got a dietary need, they'd rather not eat anything than eat the wrong thing because it could have serious side effects. And that's where the information standard again comes in, because if the ward manager or the person responsible for that patient's care is made aware that that person's got particular needs for their, they've got no sight, they've got some sight, they need information in a particular font size or whatever, then they can then set that care plan up for that person on the ward, so that all the staff will have some kind of awareness as well. So from the cleaner, the person looking after the lunches, the healthcare assistants, the nurses, the doctors, the myriad of people that are porters that come in contact with a patient in a hospital. One interesting, very simple solution that in Liverpool, that the eye clinic liaison officer came up with, who's someone who helps people connect with services in the community if they've got an eye problem. But she came up with this idea that when someone was flagged as having a visual impairment, was admitted to one of the other wards in the hospital, she would be alerted, and she would go up and just have a quick chat with the care manager and make sure that the charts of that person, when they were things that you write on, which are becoming increasingly rare because notepads and things like that, iPads and things like that are being used more. But any kind of person that would come into contact with that person who has a visual impairment would be alerted to that fact, either physically with a sticker or some other way, so that everybody from the cleaner onwards would know to kind of talk to that person and say, hello, I'm the cleaner and my name's such and such and I'm just doing this. So that, especially if you're in an isolated ward on your own, that, like you say, when someone just opens the door and comes in and goes, hello, is it a cleaner? Is it a ophthalmologist? You don't know who it is. So announcing yourself, very simple principles like that, are the key to really opening that communication and putting that patient more at ease, I suppose you could say. And just understanding the visual clues don't work. So think about how you would adapt rather your practice to take account of that fact.
All of these accessibility issues are kind of they should be everybody's problem, really, shouldn't they? Because, I mean, no matter who you are, you don't know when you might come into contact with somebody who has different needs to you. And, people might think, well, I'm not blind, I'm not in a wheelchair, I'm not autistic or whatever it might be, accessibility needs don't apply to me. But actually, particularly thinking about health, and as people get older, like, you don't really know what's going to happen to you in the future. It could very well be your personal problems. I think it is something, like, for ourselves and for other people, that we should be aware of.
Yeah, and I think whether it's your mother, your father, your auntie, your uncle, your grand, someone in your family, or yourself, sooner or later, will probably develop some kind of eye problem. If you live long enough, you certainly will, because there are conditions like cataracts and glaucoma, macular degeneration, which largely affect older people. In fact, 80% of people that we kind of categorize as having sight loss are over 65. So it's going to happen if you live long enough. But so it's good to be prepared for that, and also for your family, because I know at the moment my mother is visually impaired and her sight's recently deteriorated, and I've been the one in the family that's kind of, figured out what we're going to do about that, because she lives in a different city to the rest of us. So how do we arrange that care, and even until it's too late, until it happens, put you on the back foot a little bit, and you've got to then rush to get services in place. So just to have an eye for, as it were, to be aware of how you would deal with that if a family member did start to lose their sight. And we do a lot of resources on our website. One is called What Do We See, which using augmented reality, that posh thing where it's basically a camera on someone's head, but it sort of shows someone traveling around their daily environment, on a bus, in a shop, in the office. And it shows about 6 conditions, common conditions, what that is like to see when you've got that condition, through clever wizardry. But it shows over time how that could deteriorate as well. So if you've got macular degeneration, which is a common condition for older people, it's even called age-related macular degeneration, then it can start off not too bad, and you can see, you just maybe lose some of your vision. But if it gets worse and progresses, then it can get quite a lot worse. So it's good to see how it might progress for someone. It's only an approximation, so not everyone's going to have the same experience, but it does show family members and friends, children, and then maybe if their parents are visually impaired, what it's like for them with that limited vision, how they actually see, so they can then be more attuned to how to manage that, manage the household or whatever, to take account of the fact that people have either got maybe no central vision or no peripheral vision, so they can't see side to side, so that you need to not put things in the way because they won't necessarily see it and could trip and fall. So those videos are really good. We do one for common children's conditions as well, which has been really popular with parents and teachers and other workers in schools, so they can sort of have some kind of indication of what that child is actually having problems with in terms of seeing, and then what adjustments that they can make to help that child. Great for the classmates as well, because they can take part, they're more tuned, be more empathetic with the person, because they'll have some idea of that, because everyone's a bit shocked at first when they put we've got these sim specs, which are glasses that you put on, which simulate various conditions, and you try and walk around, and it's quite a shock actually when you've never done that before, and it really does bring home to you how limiting having reduced vision is, and how completely different your life is from that. But it's a really kind of humbling experience actually.
Have you, or has anybody had a look at a fit test with that, sort of using that kind of
tool? We've tried that out, and it's impossible.
Right.
And people with visual impairments are generally very, very resilient, and very used to having to find ways around, because as human beings, we're very adaptable. There is a serious emotional impact of sight loss, which I can't understate, and people do need to be offered support with that, because the impact of losing your sight is profound. It affects every aspect of your life. Driving is one biggie, but just being able to kind of do your hobbies like knitting or line dancing, even, which my mum does, those things can be life-changing for people, and the clinicians who work in eye health might not be aware of those, how important some of those things are to your life. So you don't necessarily need to know all the ins and outs of your medical condition. You might want to do that, and that's great, but it's what impact it has on your life that really matters, not the thing itself. So as long as I can still do this, and this, and I can have these tools to help me get around, and I've got this support with that, and learning how to use a white cane, for example, those sorts of things are essential for people to adapt to a life with reduced vision. But a lot of people aren't able to, or don't access those services, so they become isolated, and they're liable to become very depressed, which is understandable. And then it's harder to recover from a position like that. So we're really keen to reach out to people where we can, and refer them to local support where it exists, and make sure they take advantage of that.
Yeah, I think sounds like really important work that you're doing, and the whole topic of accessibility and everybody's individual needs is just so huge. I think we could talk about it all day, but yeah, just to swing back to fit tests. I mean, one thing that's stood out for me while we started talking was like, it's not the most pleasant thing to do, but as you kind of alluded to, that there's far more worse things to do. I mean, I've had bowel cancer, I've had my bowel removed, even going for a colonoscopy, having your bowel removed, having a stoma, having the stoma then reversed, potentially some things that could be avoided if cancer is caught early. So yeah, extremely important topic, and there's just a lot worse and more unpleasant things that you can do than a fit test.
And if we can help, even one person who wasn't going to do the fit test because they couldn't do it or didn't want to do it, to do it, and if one early detection of cancer cells is picked up, then that's enough really, because that's one person who's had hopefully been spared what could be a whole lot of worse outcomes. So I think that's a motivation to keep banging this drum, certainly.
Brilliant. So just one final question for you to kind of end on then. So what one takeaway would you like people to know about bowel screening and visual impairment? Kind of leave people with?
Yeah, I guess it's like, don't feel overwhelmed when you get asked to do it, and reach out and ask for help. There are speak to GP obviously is one way, but there are lots of, and as this kit gets more publicity when it's properly launched, then there will be a better way for you to get help. Some people will still struggle with it, and I guess the screening process is continually looking for ways to do this better or more easily for people, because prevention is always better than cure. And for the NHS, it's a lot cheaper as well, I have to say. So that's a motivation. Don't feel overwhelmed by it, and don't think you can't participate. You have a right under the Human Rights Act and the Equality Act to have the same care and healthcare as everybody else. And so if you are struggling because of something and you can't do it, then that's not fair. So, advocate for yourself, really encourage people to do that. You have the right to have a test. And if you find it more difficult because of circumstances beyond your control, that's not your fault. So you should be helped.
Great. Eamonn, thank you so much for coming to talk to me today. It's been really interesting discussion. Thank you.
Thanks, Sam. It's been good. Yeah, thanks. Bye.
Thank you for listening to Can I Butt In? This podcast was brought to you by Bowel Research UK. Find out more about the charity, our work, and how you can get involved. Visit bowelresearchuk.org, where you can join our People and Research Together network, or PART, read about our research, campaigns and fundraising, or make a donation to support the vital work we do. Let's end bowel cancer and bowel disease.